Great. Good morning, everyone, and welcome to the Virtual Rheumatology Learning Collaborative, which is being presented by the ACR Committee on Training and Workforce. This has been an amazing educational opportunity over 8 weeks, and it continues through the end of the month. My name is Dr. Rebecca Mano, and I'm a rheumatologist in St. Thomas in the U.S. Virgin Islands. I'll be your moderator this morning, along with my co-moderator, Dr. Jean Liu, at the University of Washington. Couple of housekeeping items over the next hour during the lecture. The chat function is to be used for general comments. You can use the raise your hand function if you're having a technical issue with the system, and one of our staff will assist you. Finally, the question and answer tab is used to post questions regarding the lecture content, and those will be addressed at the end of the talk. Finally, please make sure after this session that you do complete the survey that you'll receive in the email. Your feedback is really important as future educational events are going to be planned in similar formats. So now, without further ado, I'd like to welcome our lecturer for today, Dr. John Reveille. Dr. Reveille went to medical school at Johns Hopkins, where he also did his rheumatology fellowship. He was on the University of Alabama rheumatology faculty from 1980 to 86 and has been at the University of Texas, Houston since 1987, where he was chief of rheumatology from 2002 to 2019. His research has been on genetic and outcomes in rheumatic disease, particularly spondyloarthritis, lupus, and scleroderma, and we are delighted to have him here this morning to talk about non-radiographic axial spondyloarthritis. Thank you so much for being here.
Yes, it's a real honor to be asked to speak here today. And I want to also thank our co-moderator, Dr. Jean Liu, for, we went over these slides beforehand, and she wanted to make sure that this did not too heavily and significantly overlap with the SOTA lecture that I gave on Saturday, which was essentially on the same topic. This will be rather different, as you all will see presently. Again, here is the title, Non-Radiographic Axial Spondyloarthritis. These are my disclosures. So basically, this is a very old slide. This is how we used to think about ankylosing spondylitis and what we called back then the spondyloarthropathies, of which ankylosing spondylitis was the more classic presentation, but also a variety of other related diseases like the arthritis, ulcerative colitis, and Crohn's disease, juvenile spondyloarthritis, undifferentiated spondyloarthritis, psoriatic arthritis, and acute anterior uveitis and reactive arthritis, previously known as Reiter syndrome, were all part of the spectrum. That has changed, and now we really consider spondyloarthritis as falling into axial spondyloarthritis, of which ankylosing spondylitis is a subset, and peripheral spondyloarthritis, where we have psoriatic arthritis, which can also have an axial component, reactive arthritis, likewise, which can have an axial component, the arthritis associated with inflammatory bowel disease, and undifferentiated peripheral arthritis. This all began, it began back in 1966 when the initial New York criteria for ankylosing spondylitis were proposed. Seth van der Linden modified them in 1984 to take it from just chronic back pain to chronic inflammatory back pain, which are what we really see under the clinical criteria with low back pain and stiffness for 3 months, which improves with exercise, but is not relieved with rest. Limitation of motion of lumbar spine in both the sagittal and frontal planes, as well as limitation of chest expansion. And of course, the sine qua non, the radiologic criterion of at least bilateral grade 2 sacroiliitis, or unilateral grade 3 and 4. And of course, you had to have the radiologic criteria and at least one of the clinical criteria. That changed because of the realization that it takes 7 to 10 years from the time that the inflammatory back pain actually begins until the x-rays actually turn positive. And then even later than that, we'll see the development of syndesmophytes. And that these people, as you will see, were pretty much disabled even before the x-rays turned positive. Initial attempts to dealing with this problem began with the Amor criteria, which you can see on the left there, which were proposed by Bernard Amor in 1990. And that actually had a nice scoring system. It weighted the individual criteria, and including the presence of B27. And you had to get 6 or more points to meet criteria. These are, of course, classification criteria. A year later, the Maxime Degados chaired a committee with the European Spondyloarthritis Study Group criteria, which had either inflammatory back pain or synovitis, asymmetric and predominantly lower limb, and one of the following variables. And this has been used in most of the epidemiologic studies of the frequency of spondyloarthritis, including in NHANES that I'll talk about later. And of course, this comes from an era when we were dealing with making a diagnosis via radiographs. And of course, on the left, you can see a relatively normal thick SI joints as they're supposed to look. And on the right, you see grade 4 or complete fusion of the SI joints, as well as the typical bamboo spine that we see in people with advanced ankylosing spondylitis. More recently, however, the MRI technology has come on, and that has helped us a great deal in making earlier diagnoses. And that led to the development of the ASAS, the Assessments in Spondyloarthritis International Society classification criteria for axial spondyloarthritis, which started with a patient with chronic back pain from greater than 3 months and age at onset less than 45 years. And that age of onset less than 45 years is going to be very important as we deal with this topic later. And they could either have the so-called imaging arm, which was circulated by imaging. This would include, remember I said before that ankylosing spondylitis is a subset of axial spondyloarthritis. So it would be sacralized on imaging, which could either be on MRI or on standard radiographs, plus one of these spondyloarthritis features you see in the gray box, or being B27 positive and having at least 2 of those features. The imaging arm had a okay sensitivity, a very good specificity. The clinical arm, we can see that's the sensitivity and the specificity there. And of course, this all, the introduction of the positive MRI of the SI joints, because the MRI of the spine is not really helpful. It's non-specific. From such cohorts as Desir and Space from Europe, we have learned that. So we really focus on the sacroiliac joints to try to make a diagnosis. And of course, these were the classic ASAS criteria for a positive MRI, which was MRI evidence of bone marrow inflammation with either bone marrow edema on T2-weighted sequence, sensitive for free water, or on stir images. And the inflammation must be clearly present and located in the typical anatomical area, i.e. subchondral bone in the SI joints. And the MRI appearance must be highly suggestive of spondyloarthritis, so taking into account other features. So the question is, can we do a better job in making a diagnosis in these ASAS criteria? Well, let's look at genetics, first of all. And of course, the 600-pound gorilla in the room here is HLA-B27, present in whites and Asians in 90%, 85 to 90%, also in reactive arthritis and psoriatic spondylitis, as well as enteropathic spondylitis, less so with peripheral disease. And you'll see the prevalence in normal Caucasians, which really comes from NHANES at 7.5%. Of course, B27 has been around a long time. It came originally from the parent subtype, which is B2705 from Africa. And as man left Africa 50 to 80,000 years ago, we saw the other major subtypes developing, B2704 in Eastern Asia, 07 in Western Asia, B2702 are in the Mediterranean and Europe, and then B2706 and 9, which are not associated, by the way, with AS, which came in Southeast Asia and Sardinia, respectively. And of course, we know B27 has a lot of subtypes. They're derived from the major subtypes I showed you in the last slide, 05, 02, 04, etc. And as of present, we know of 222 different subtypes of HLA-B27. Now, most of those are very rare, but we do know that B2705, the parent subtypes associated with spondyloarthritis, as well as B2702 in the US and in Europe, B2704 in Eastern Asia, 07 in Western Asia, B2715 in China, and a possible association with B2714 and B2701 B2706 in Southeast Asia and B2709 in Sardinia are not associated with ankylosing spondylitis. And the others are just too rare to have had an association established. Of course, NHANES actually looked at the prevalence of B27 at a population-based frequency in 2009, and we found that the frequency overall is 6.1%. That is more common in whites, is 7.5%. In Mexican Americans, it's 4.6%, and a much less common in non-Hispanic blacks. What's interesting is we saw the frequency fall off significantly with age, and that's going to be important when we start talking about late onset spondyloarthritis. And of course, a lot of other genes have been discovered with AS. Look at this circle right here. We also know there's a lot of overlap with the genes for ankylosing spondylitis, for Crohn's disease, ulcerative colitis, and psoriasis. We now know of up to 133 different genes that are associated with susceptibility to ankylosing spondylitis. Of course, the issue here, and this is an older slide looking at SNFs that we reported back in 2013 we in collaboration with Matthew Brown's group, who at the time was in Australia. And we see I want you to look at the odds ratios here. This is B27 and associated genes in the MHC are the 600-pound gorilla in the room here with an odds ratio of 60. Look at the odds ratio for the other genes. They're all around 1, so really quite low. And so individually, they add very little to the diagnosis. It's really B27 is the big monster here. So the question is whether or not we can use genetics to make a diagnosis. And this is a work that's actually in press in Nature Communications currently. And genetic profiling can be informative to developing disease symptoms. Polygenic risk scores convert genetic data to a measure of risk of disease. Especially if you use only definite loci, you only have limited discriminatory capacity. So the aim was to develop and validate an optimal polygenic risk score to assist the early diagnosis and to identify subjects at high risk for developing AS. 8,244 Europeans, including 1,002 people from the US. 6,000 Eastern Asians were used, and those had nervous controls. And we also had 910 Turkish and 430 Iranian AS patients. And if we looked at just the variants that were seen at genome-wide significance by themselves, we really see that the area of the curve isn't fantastic. It's good, but not fantastic, but that's sensitivity specificity. Adding the paradigm that we use for the polygenic risk score, which is take all SNFs over that are better than a p-value of less than 1 × 10 to the -5, and the SNFs around them, we look at them by themselves. We get a better area under the curve at 78. Looking at B27 by itself, even a better. Now, this is just looking at B27. We see a decent area under the curve. But if we add in those other SNFs that are at a significant level of P less than 1 × 10 to the -5, the surrounding SNFs and the MHC SNFs, we find that we get a very good area under the conserve and very good sensitivity and specificity. And you look at that when you compare it to MRI. And this panel costs $55, as opposed to MRI, which costs $2,500. And of course, CRP, which performs less well, which really underscores that this has some utility in diagnosis. Now, if we compare the various criteria that are out there, modified ESSG, modified ESG, this is taking into account a positive MRI, and the OSIS criteria, we find that the OSIS criteria do perform pretty well. This is a recently published study by Boel et al. That included patients from the US, from the UCSF cohort, part of SOAS, and the other groups that are largely going to be coming from Europe. And we see that actually looking at the patients fulfilling modified New York criteria or OSIS criteria, that really they perform pretty similarly. This is also underscored here. These are the various groups I've already talked to you about. And we look at those who were positive for New York and negative for OSIS, relatively few. Negative for New York, positive for OSIS. Again, we see here, and it underscores the fact that probably, and this was looked at the last OSIS meeting, or a year ago, rather, not the most recent, and that indeed the OSIS criteria do also perform very well to predict AS. So talking a bit about chronic inflammatory joint pain, we see that there are 4 different sets of criteria out there. The Galen criteria started, then the European Spondyloarthritis Study Group criteria, the Berlin criteria, and finally the OSIS criteria. I will tell you that recent studies have shown that the Berlin criteria performed the best. Again, you can see here, all of them have patients that are young. Morning stiffness, improvement with back pain with exercise but not with rest, awakening with back pain during the second half of the night only, and alternating buttock pain. And if you get 2 of the 4 of these, you meet Berlin criteria. We used the Berlin criteria to look at the prevalence of inflammatory back pain in NHANES 2009-2010, and lo and behold, we had found an overall prevalence of chronic back pain in the U.S. of 19.4%. And it's very clear that 1/3 of those people met the Berlin criteria for inflammatory back pain. So 1/3 of people with chronic back pain had inflammatory back pain. But look at this. Between the ages of 40 and 69 years, 5% of the people had chronic inflammatory back pain. Of course, it's more common in the younger people, as you might expect. But inflammatory back pain as a concept, looking at likelihood ratios, this is something that Martin Reveille proposed back in 2005 before the OSIS criteria were actually developed. And he looked at the individual components that would ultimately be the OSIS criteria. We see how that the likelihood ratios perform quite differently with, of course, the presence of B27 or imaging positive performing the best. And there's some question because there's been some concerns raised about if we can improve the OSIS criteria, and that's currently being looked at with the classic study done in the U.S. in collaboration with OSIS, and to reassess the OSIS criteria in independent groups of patients to see if indeed we can improve that specificity from 84 to 90%. Now, what about inflammatory back pain commencing later in life? If you'll notice, these criteria we've already been over all deal with early onset disease, as you can see. Well, if I've already shown you that 5% of the people between the ages of 50 and 69 years at NHANES had inflammatory back pain. But the reason why the people who developed the OSIS criteria and the other criteria were concerned about applying inflammatory back pain later in life is that there is a differential diagnosis, not just late onset axial SpA, but also polymyalgia rheumatica. Fibromyalgia in some patients can have some inflammatory-like symptoms, Paget's disease, and even osteoarthritis. So there is an overlap there. So what we did was and these data are unpublished, going back to NHANES 2009-2010. The 5,107 participants, nationally represented people, there were 1,917 who were over the age of 50, of whom 116 had low back pain or buttock pain almost every day for 3 or more months. And lo and behold, we ended up applying the Berlin criteria that 2.9% of the people between the ages of 50 and 69 years had chronic inflammatory back pain beginning over the age of 50. What does this represent? Well, we really don't know because we've actually just completed a systematic literature review, and there's not a single article that's ever been published that has addressed this. But clearly, this is an unmet need. And this is a problem because outside of rheumatology, the concept of chronic inflammatory back pain is basically unknown, okay? And this is looking at North Carolina insurance databases, only 14.1% of patients with chronic back pain were ever seen by a rheumatologist. These guys who don't know what chronic inflammatory, don't consider what chronic inflammatory back pain as a clinical entity are the ones that are seeing all the patients, not us. It's even worse when we look at when spondyloarthritis most typically begins, which is below the age of 45. Only 9.1% ever saw a rheumatologist. So again, this is a real unmet need. Let's move on to talking more about axial spondyloarthritis. And you've already seen this slide. And these are older data from GESPIC, with 50% having non-radiographic axial SpA, 50% having ankylosing spondylitis. If we were to use the NHANES prevalence, it'd be more like 67% here and 33% here. Nonetheless, there is this, the New York criteria met this group. The new OSIS criteria, which are not diagnostic criteria, would encompass the whole group. And in fact, if we now we did NHANES 2009 2010 before the OSIS criteria were developed. So we used the ESG criteria, and lo and behold, we found a prevalence of 1.4% of people in the U.S. met ESG criteria for axial spondyloarthritis. What's also interesting that 29 of the 5,103 people had a diagnosis of ankylosing spondylitis made by a physician. And so what's interesting about that is that we go to the original NHANES back in between 1971 and 75 that looked at 6,913 people. They found that the prevalence of moderate to severe sacroiliitis in the U.S. population was 0.52%. So very similar numbers, and probably represents the real disease. Now, Jeff Curtis looked in the Kaiser Permanente data set and found rather lower point prevalence of AS, 2.26 per thousand people per axial SPA and 1.07 for ankylosing spondylitis. The problem was that less than half of these saw rheumatologists, and so he suggested that the observed prevalence is probably much lower because of substantial, than what the truth is, because of substantial recognition of these conditions in routine clinical practice, unfortunately, is really not being done. Ruben Burgos-Vargas looked at 51 rheumatology outpatient clinics in 19 countries in Latin America, Africa, and Europe. And they found that 38.7% of these people with chronic back pain fulfilled the criteria for inflammatory back pain, so even higher than what we found in NHANES, of which 29% of them met criteria for non-radiographic axial SPA, and 53.72 met criteria for AS. This prevalence of non-radiographic axial SPA varies significantly by region, with the highest prevalence in Asia and the lowest in Africa. Atul Deodar, and we were actually collaborators in this study, looked at 697% of patients being evaluated for chronic back pain and found even higher frequencies of axial spondyloarthritis. And his data suggested that among patients with back pain for more than 3 months, beginning at less than 45 years of age, the presence of greater than one of 3 SPA features is an effective way to identify those with possible axial SPA. This was published just a couple years ago and underscores the unmet need that we're really dealing with in the U.S. So if we compare, these are some of the older studies comparing patients with new onset ankylosing spondylitis with those with axial SPA, either using ESG criteria or OSIS criteria. And what we found that they were similar in a lot of clinical features, except that there was a much lower proportion of males in the 3 groups that had axial SPA compared to ankylosing spondylitis, and that there was a substantially higher CRP, C-reactive proteins, in those with ankylosing spondylitis compared to those with axial spondyloarthritis. The Desir cohort is particularly interesting because this is a longitudinal multicenter French cohort of patients with inflammatory back pain, suggestive spondyloarthritis, and the key thing about this cohort is that they're following them for up to 10 years. They collected a whole bunch of demographic data to specifically allow classification and to look for follow-up to progression from axial SPA to ankylosing spondylitis. And if we look, this is the paper that was just published just 2 months ago or 3 months ago, and that the prevalence, the black bar is radiographic axial SPA or ankylosing spondylitis. The gray bar is those with non-radiographic disease, and that the prevalence of peripheral arthritis, enthesitis, backflash, uveitis, IBD, and the like was pretty similar. If we looked at how are the BOSDI, BOSFI, and days of sick leave, there's a trend towards even worse performance in those with non-radiographic axial SPA. Again, that's shown again on this particular slide, where we see that in particular there was more peripheral arthritis in the radiographic AS cohort, and looking at the other features associated with disease severity, The most significant, of course, was as we showed in the earlier, the other cohorts, that there was that CRP was more likely to be elevated in those with ankylosing spondylitis. But there's also a trend towards if you look at non-radiographic versus radiographic disease, higher BOSDIs, that's worse BOSDIs, of course, lower spinal involvement in the non-radiographics, as you expect, more functional impairment, and greater days of sick leave in those with non-radiographic disease. Of course, when they went ahead and adjusted for age, sex, and TNF usage, only CRP came out as significant. But nonetheless, that trend was there, and it underscores the fact that non-radiographic axial SpA is a serious disease that really does impact the lives of the patient. This is another cohort that was reported last November by Zhao et al., looking at the U.S. And among 965, 775 or 80% had axial SpA. Another cohort, they found that AS patients were significantly older than those with non-radiographic axial SpA. And just like the other studies, there was a higher median CRP in those with radiographic axial SpA. And that the most commonly described biologic DMARDs were adalimumab and etanercept. This is like a cross-sectional look at patients with AS and non-radiographic axial SpA from the US, but more or less showing the same things that we've already talked about in the other cohorts. Now, what about late onset axial SpA? There have been a number of studies out there, beginning with two very small series in the 1990s, as well as more common ones, including when we looked at the SOAS cohort, and this paper is currently being sent out for review right now. And what was found in the bottom line was actually that in late onset axial spondyloarthritis, that there was a lower frequency of HLA-B27, much lower frequency than looking at those with younger onset disease, as well as a higher frequency of enthesitis and peripheral arthritis. So this disease does indeed start. We found 2.1% of our AS patients had disease onset over the age of 50, 7.9% of those from Turkey, 3.5% of those from Taiwan, 3.5% of those from Spain. Of course, the series from Senegal and from Japan were mainly spondyloarthritis in general, where the other cohorts were ankylosing spondylitis. What about progression from non-radiographic to radiographic disease? Looking at some of the older studies, we see that at greater than 10 years, there's still a large proportion that have not gone on to progress to radiographic axial spondyloarthritis. Dennis Podobny actually looked at the GESPIC cohort for those that went from non-radiographic to axial SpA. They found 12% in 2 years, and that in particular, the presence of an elevated C-reactive protein was the best predictor of those that would go on to develop ankylosing spondylitis from non-radiographic disease. Maxime Degados looked into the ZIR cohort, and they had found actually much lower frequencies. Only 5.8% actually progressed from non-radiographic to radiographic axial spondyloarthritis after 5 years. In fact, a few of the x-rays actually got better, which is more an indication probably of how imperfect x-rays are to assess progression of this disease. Nonetheless, very low progression. And that they found that the progression was most likely to be seen in the B27 positive group, especially those that had inflammation on the SI joints, as well as those, as we've seen before, with elevated C-reactive proteins. The others really weren't as significantly seen. In the B27 negatives, it was much less robust in the actual progression to AS. Runxing Wang, who's now at Columbia, when she was a fellow with Dr. Michael Ward, looked at the Rochester Epidemiology Project and those who enrolled between 1985 and 2010, and in conjunction with Shereen Gabriel at the Mayo Clinic, found that the probability of the condition would remain as non-radiographic axial SpA at 5, 10, and 15 years. That the condition would remain as non-radiographic was 93.6% at 5 82.7% at 10, and 73.6% at 15 years. So a very large proportion of these patients with non-radiographic axial SpA actually, even over time, remain thus. This is looked at in a paper, further looked at in a paper by Hebison et al. That was published in PLOS ONE earlier this year. We looked at those radiographic versus non-radiographic disease. This is some spaghetti plot looking at MSAS. So basically, we're just looking at progression of the MSAS. And what we find that those with radiographic disease are much more likely to have X-ray progression than those with non-radiographic disease. So this is a very stable phenotype. And that the most important thing, and Dennis Podubna showed this earlier, that baselines and decifieds were predictors of further progression. So talking about treatment, this is the last part of the talk. That this is looking at the 2019 update of the American College of Rheumatology SAA Spartan recommendation for the treatment of AS and non-radiographic disease. That the recommendations for AS and non-radiographic axial SpA are similar. TNF recommended over IL-17 blockers. However, if the patient fails their TNF, the recommendation is to go to an IL-17 blocker instead of going to a second TNF inhibitor. That co-administration of low-dose methotrexate is not recommended. Sulfasalazine is recommended only for those with persistent peripheral arthritis and for patients with unclear disease activity. That spine or pelvic MRI could aid in assessment, but that routine monitoring of radiographic changes with serial spine radiographs is not recommended. That's a research tool. And that biologic therapy we know is effective in axial SpA. We've seen that now with etanercept, adalimumab, infliximab, certolizumab, and ixekizumab most recently. But among the TNF blockers, only certolizumab has been FDA approved for use in non-radiographic disease. So that although population-based estimates of the prevalence of axial SpA and AS in the AS in the United States suggest prevalence as high as 1.4% and 0.5% respectively. What is counted by rheumatologists is much lower, possibly because the overwhelming majority of patients with chronic back pain are never seen by rheumatologists. The IASIS criteria are currently the gold standard for the classification of axial SpA, but whether or not they can be improved is being evaluated. Genetic testing better improve diagnosis? That is now being looked at. Non-radiographic axial SpA has similar features, except for higher levels of CRP in those with AS compared to axial SpA. But the burden of disease seems to be the same, if not higher, in those with non-radiographic disease. Progression from non-radiographic axial SpA to AS is relatively low, highest in those with positive MRIs. And chronic inflammatory back pain axial SpA usually develop early in life, but can occur de novo in the elderly, a sign that needs further, a finding that needs further evaluation. And I'd be happy to take any questions that you have right now. This is from John Atkinson of a snake with ankylosing spondylitis, which you might guess would be pretty disabling for that snake.
All right, are we ready for questions? And also, can people hear me?
Yeah. Perfect.
Okay, so the first question is our bar for trialing biologics in non-radiographic patients with inflammatory back pain too low? And this person is specifically concerned about the possible side effects from chronic use of NSAIDs and opioids in such patients. And they're wondering if in these people, is it worth a trial of biologics, even if the patient is presenting without other SpA features?
That's an outstanding question, and especially when we look at the impact of chronic back pain in the community, which I didn't get into in this lecture. I got into that in the previous lecture. And I think in the long and the short of it is, and I know the drug companies would love to hear this, but I think in people with refractory inflammatory back pain, we know that non-steroidals do help, but where that's contraindicated, whether a trial of biologics might be in order, is something that's going to have to be looked at. There really aren't good data on there as of present. And believe me, I in our systematic review, when we reviewed all of these data, so that is a question that needs to be further define as we define, especially in groups that have not been looked at, like the elderly, what this concept of inflammatory back pain actually is.
And I think there's, along the same lines, there's a follow-up question of, can a patient have non-radiographic axial spondyloarthritis without any positive imaging? And what type of factors would go into that?
Well, that's why we have the so-called clinical arm of the OSSIS criteria with B27 and one of the, instead of one, but two of the features. I think so. The answer is, as far as what the state of the art is, yes. The answer is yes. So just because the MRI is negative doesn't mean you should, particularly if the CRP is elevated and if they're B27 positive. I think you get into some more problematic ground when you're dealing with a MRI negative, CRP negative, B27 negative patient. And you know, I have some of these in my practice. They're MRI, CRP, B27 negative. They come to me already on a biologic, swearing that the biologic is helping them. You know, I usually continue the biologic in those people. Of course, they often have their disability papers in hand, and that's a whole other issue in itself. But you know, the fact of the matter is that some of these people may be trying to snooker you, but occasionally you're going to get the real patient, and to not treat that patient, deny that patient treatment when they really have disease would be a travesty, as far as I'm concerned. I give the patient the benefit of the doubt.
Okay, so this one is about obtaining the most sensitive and useful imaging studies so that you are able to make diagnostic and therapeutic decisions. Do people need to stop NSAIDs or other medications, including anti-inflammatory medications, prior to obtaining the MRI or other related imaging study? And if so, for how long?
Oh, that's a very good question. And I don't think there's an easy answer to that. First of all, the question is whether or not NSAIDs or TNF change the MRI. We know from a variety of studies that TNFs will decrease bone marrow edema seen on imaging. We certainly know that. That's been well demonstrated in clinical trials. As far as radiographic progression is concerned, there are most studies show that TNFs over time, it takes at least 4 years before you really see an effect, do inhibit radiographic progression. Not all have shown that, however. The early trials that did not show it were just followed. It was only 2 years of follow-up, and that's not enough time. There are also data showing that NSAIDs can slow radiographic progression. But again, there are positive and negative studies in that regard. If you look at clinical trials, they usually demand a 3-month washout. That's pretty long time to keep your patient off of treatment, but that may be what's necessary. Those kind of still need to be done.
Great. The next question is, in patients with spondyloarthritis and inflammatory bowel disease who have failed a TNF inhibitor, what would be your next step for management?
That's a very good question. Okay, you obviously are getting into some shaky ground if you're going to give an IL-17 blocker to these patients, because that can cause a flare of their IBD, and it's certainly happened in my practice. Where patients had very remote histories of inflammatory bowel disease, which would not be a contraindication to using an IL-17 blocker, and then had significant flares of their IBD when I put them on an IL-17 blocker. I think the promising area, are going to be the JAK inhibitors in that regard, because they're approved for IBD, and they're currently in clinical trials. In AS, I use them off-label in my own practice. I'm not supposed to be making these recommendations in the talk such as this. That's a promising area for the future, but again, the work needs to be done. Underscoring the efficacy and safety of JAK1 inhibitors in AS, and that's being done right now.
Okay, thank you. I promise I didn't write this question myself. Thank you to the person who submitted this. But they said, can biologics prevent progression of radiographic damage?
Yes. We were actually, we meaning we working with Nigel Haroon was the first author, Leanne Gensler was the senior author on the paper. Actually, in the SOAS cohort and the Toronto cohort showed this back in 2013. That it does. And a much smaller group of patients, Zina von Berry-Lacke showed the same. It's been since seen among the Swiss and the like with TNF blockers. Of course, we have the WANDER study for NSAIDs, one from Dennis Podubny, which shows some suggested data in that regard. And then finally, the Jochen Sieper looked at diclofenac. They used celecoxib. Jochen Sieper looked at diclofenac, which did not show a difference. In fact, there's more progression in the diclofenac group. But for TNF blockers, we clearly see that. I am at this point not aware that the IL-17 data haven't actually been published. But I'm sure we're going to see the same thing because persistent inflammation is the best predictor of radiographic progression. And again, I just don't recall if those data have been published already. And likewise for the JAK1 data, which are currently just being done.
Great. So the next question is about sulfasalazine. Can you comment on the use of sulfasalazine for axial disease, as it is used sometimes in resource-limited settings with some success? And overall, can you expand on the role of conventional synthetic DMARDs, which may be used in resource-limited settings in this way?
Well, first of all, methotrexate is not recommended, and there's no evidence that it works. So let's throw that to the side. But let's focus on sulfasalazine. If we look, there have been many trials that have been conducted. One of the largest being the VA cooperative study that Dan Clegg was the PI on. And that showed the only impact was on peripheral arthritis, not axial disease. Maxime Dugados oversaw the European study that actually showed that it was the only one that showed a marginal impact on axial disease. There have been 13 other studies that have been published, none of which have seen any impact. That said, until the introduction of biologics in the early 2000s, we routinely use sulfasalazine in these patients, and I suppose that sulfasalazine could be used in these patients. I have resource-limited patients myself, and I have many of them on sulfasalazine.
Okay, so I have two kind of related NSAID questions. So the first one is, do you have a preferred NSAID for non-radiographic AxSpA or any SPA? And then the second part is, would you continue NSAIDs in those who have been started on biologics, with the person asking, quote, would you keep patients on NSAIDs forever?
Well, those are both very good questions. Well, first, as far as the NSAIDs are concerned, there appears to be some impact on radiographic progression. As far as do I have a favorite one? Well, if we stick by the ACR, Spartan, and as well as the EULAR, OSIS treatment guidelines, no NSAID is recommended. We do have some unpublished data that suggests that, and if you look at the WANDER study, which used celecoxib, the study that likewise used that, and then finally the CEPR study used diclofenac, the celecoxib seemed to have a better impact on radiographic progression. And we have unpublished data that Leanne Gensler oversaw that in the SOAS cohort, which showed the same thing, comparing celecoxib with the other NSAIDs. So I would say, I have a personal preference, but as far as the official guidelines are concerned, none is recommended. As far as a TNF blocker, your NSAID with your TNF blocker, the guidelines tell you that the patient is doing well that you should not be continuing NSAIDs. I think I would continue to follow those patients, and if there's any evidence of clinical deterioration, you're clearly going, if they're in remission or very well controlled with low disease, very low disease activity, the recommendation is, again, to stop the NSAID, just continue the biologic. However, if symptoms do recur, clearly you want to put the NSAID back in. I've talked about our unpublished data on radiographic progression showing that the combination of an NSAID and a TNF blocker have a superior effect on slowing radiographic progression. But I think I'd like to see that go through peer review and be published before I would want to stand firmly on that recommendation.
Could you expand further on why the guidelines currently recommend stopping the NSAID if they have stable disease on a biologic?
Because of the risk of NSAIDs, particularly in the elderly, and that as of present, there aren't any other data that have shown that this interaction is salubrious.
Okay.
Great. So the next question is, can you identify a clinical phenotype that would respond better to IL-17 inhibition versus TNF-alpha?
It's the question. I guess it depends what you mean by response. Clearly, the people with psoriasis are if you're using that as your assessment, are going to have a better response to the IL-17 inhibitor. But as far as the musculoskeletal disease is concerned, I really, as far as peripheral arthritis is concerned, the answer is no. As far as axial disease, the answer is no. Acute anterior uveitis seems to do better with the TNF blockers, as does inflammatory bowel disease. So I guess that's the best we're at right now unless something's been published I'm aware of.
Okay. What are your thoughts on exercise as relating to progression of disease, especially given MRI studies that have shown similar looking MRI changes in athletes?
Yes, good question. Okay, so I'm obviously, if you go even to the chronic back pain literature, without any question that physiotherapy and exercise programs and then look at Cochrane reviews and they very clearly give you a better result. Data from our group, as well as from others, have suggested that people who exercise at least 120 minutes a week have a better response to their biologic. They certainly have superior data looking at Michael Ward actually looked at this issue of supervised exercise programs when he was at Stanford, and has followed it up later. And Dr. Boonin from Europe has done the same. It's very clear that people who exercise and as well as supervised exercises have better outcomes than those who don't.
As a follow-up question to that, can you just comment on the type of exercise that would be recommended and preferred in terms of a prescription for exercise to a patient?
The Spondylitis Association of America actually has an exercise on their website, an exercise program, and it's very clearly that functional studies of AS patients have shown that activities involving trunk twisting, bending, and the like are the ones that are most impaired in people with spinal arthritis. And so these spinal mobility exercises are very important. I suggest you look on the website. We always direct our patients to it. And that would give you a nice and well-vetted set of exercises that will help you to maintain spinal mobility. Going beyond that to actually conditioning, obviously it's very cardiovascular training is going to be very, very important. For those more impaired, walking is a good place to start. But for those that can jog, for using ellipticals, exercise bicycle, all those kinds of things will help this kind of cardiovascular training as well as muscle training that gives you a much better outcome. There's a general prescription in especially in older people that some degree of weight training is also going to be necessary.
Great. So the next question is, how long do you continue biologics in spondyloarthritis?
That's a very good question, and I think the only criteria that really assess this were the EULAR criteria, which recommended that a person with at least 1 year of total remission or very low disease activity, that you consider tapering, if not discontinuing their biologic. We do know from other studies that about 70% of those people will ultimately flare again, but that's the it should be at least a year.
Okay. And then this question always gets asked, but I think it comes down to whether you're a lumper or a splitter. But do you think non-radiographic AxSpA is a completely separate disease entity?
Okay. Here's the issue. We know that ankylosing spondylitis is by and large a subset of axial spondyloarthritis, okay, or radiographic versus non. I think we've got some issues here that I think this is more an issue of performance of the criteria than it is the actual disease. Because I think part of the issue is why we need to get the specifics better is that there is going to be some bit of an overlap with entities such as fibromyalgia and the like. So I personally think that there's very clearly a large group of patients with true, and I have a lot of these in my practice, people that I have followed for 10, 15 years with high CRPs, a lot of peripheral joint and disease and axial symptoms, positive MRIs of the spine, who never go on to progress to ankylosing spondylitis. And the diagnosis of spondyloarthritis is absolutely unquestionable in those. I think that when the further genetic studies are done, we're going to see that we might be able to sort these out. Matt Brown did attempt a study on 345 patients from ASAS of looking at the most highly disease-associated non-MHC genes. And really, that ended up being a negative study, but I think that was a problem with power, because 345 patients were looking at these studies of non-MHC SNPs is a relatively small sample size, and that axial SpA is a more heterogeneous disease than is the more tighter ankylosing spondylitis concept. And so I think that ultimately further studies with genetics are going to help us here.
All right. Actually, I've got one more question, and this will be the last one. But this is a question relating to why methotrexate is not recommended when be added to prevent HACA formation for other rheumatic diseases. Why is it not recommended for use in SpA?
Well, I think the best reason is that unlike in rheumatoid arthritis, the presence of anti-drug antibodies is less predictive of outcome in SpA than it is in rheumatoid arthritis. And I have seen abstracts presented at the ACR that show an effect of methotrexate on these antibodies, but there just aren't good data that it makes a difference. And I think until those data are published, that's the recommendation.
All right. Thank you, Dr. Reveille. So that ends all these excellent questions. And thank you everyone for coming. Please don't forget to fill out the survey that Ngozi will be sending you via email following this talk. And don't forget that we have other talks coming up this week. With that, we'll end. Thank you, everybody.
Thank you.
Thank you.